Good afternoon. I'm Professor Shane Darke and welcome to the weekly NDARC webinar broadcast to you live from the ballrooms of Mars. Now, while we are widely dispersed, we acknowledge traditional owners of country throughout Australia, recognise their continuing connection to land, waters and culture. We pay our respects to their elders past, present and emerging. Now, it's my great pleasure this week to introduce one of NDARC's rising stars, Samantha Colledge. Sam's been with us since 2016, so she's turning into a bit of an old timer, really, Sam. She's in the third year of her doctorate at NDARC. She specialised in harms relating to injecting drug use, and Sam over those years has led and assisted work on overdose, mental health problems, bloodborne viruses, and the characteristics of people who inject drugs. Now, in this presentation, she's going to talk on something that is really frequently overlooked, which is injection-related injuries and diseases. A great deal of focus over the preceding decades has fallen, and rightly so, upon bloodborne viruses such as hepatitis C. But far less attention is actually being given to injection-related injuries and non-viral diseases. And despite the fact that these are actually, for people who do inject drugs, report them as major problems. Now, Sam in this presentation will present data on the prevalence and patterns of harms, such harms drawn from a large national survey of people who inject drugs. And I should point out that this is work that has just been accepted by the prestigious journal Drug and Alcohol Dependence, and it's very much hot off the press, this work. Now, you can log your questions into the Q&A Zoom function, which I'll relay to Sam at the end of the presentation. To give people a chance to ask questions, request 2 per person, please, at the most, and we may not be able to ask all of them. So, without any further palaver, I shall say now, Sam, it's over to you.
So much, Shane. And good afternoon, everybody. As Shane said, I'm Samantha Colledge. I'm a PhD student at NDARC. I'd also like to acknowledge the traditional custodians of the land and pay my respects to elders past, present and emerging, and also extend that welcome to the Aboriginal and Torres Strait Islander people joining today. So thank you so much for tuning in this afternoon. Today I'm going to be discussing one of the major outcomes of my thesis, which is injecting related injuries and diseases. I remember when I decided to do a PhD, I wasn't entirely sure what I wanted to work on. I asked my supervisors, Sarah and Louisa, what was an issue that they thought potentially needed more attention, was quite important but not really getting the attention that it deserved. And they suggested injecting related injuries and diseases. And I'm really glad that they did, because I find it such an interesting topic. And more importantly, as Shane kind of mentioned, these harms are actually really easily avoided with simple behavioural changes. So hopefully it's just a matter of shining the light on it. So I hope everyone learns something today, or at least enjoys. I'll begin with a little bit of a background into what I mean when I refer to injecting related injuries and diseases, and then give an overview of the study that Shane just mentioned. So to begin, I've provided a little definition. So injecting related injuries and diseases typically means non-viral harms that are a direct consequence of injecting drug use. So non-viral, obviously indicating that this excludes HIV and hepatitis, which are often kind of studied among people who inject. It often also excludes things like effects of drug toxicity, so overdose, but that's not always the case. And then sometimes it'll include indirect consequences of injecting drug use. So things like amputation, which aren't, you don't inject and cause amputation. It'll be a sequelae of some other harm. Sometimes it'll include non-harmful consequences of injecting, such as vein collapse, in and of itself not harmful, but can sometimes be kind of brought into the mix. The most common harm that's looked at are skin and soft tissue infections, and they kind of hold this balance of being quite harmful, quite prevalent, and also requiring some sort of treatment or at least care. So synthesizing the evidence is quite tricky. Some papers don't even define what they mean by this term at all. So what I'll do is give a brief overview of the more common harms. Firstly, looking at diseases. So these are the consequences of bacterial or fungal infections. Two major causes, or two behavioural causes at least. So the first is using unsterile injecting equipment. This could be reusing one's own equipment or using someone else's. The second is having an unsterile injecting site. So people often will wipe their skin to get any bacteria away from the skin surface. And this is to avoid the transfer of bacteria from either the equipment or the skin into the skin, soft tissue, subcutaneous tissue, or bloodstream. So as I said, skin and soft tissue infections are the most common. I've got a couple up here. So abscess wounds, I'm sure everyone might have seen an abscess wound. So it's a bit of a pus-filled lump on the skin. Cellulitis is more like a red rash. Necrotizing fasciitis, much less common, but it's effectively bacteria that has infected the soft tissue and the fascia. So the fascia is like a sheath that is covering a muscle, and the bacteria is starting to like attack that muscle or attack that fascia. Wound botulism only really occurs in people who are injecting not into their vein, but into their subcutaneous tissue. So by creating this sort of wound, and by a particular germ called Clostridium botulinum getting into this wound, that can turn into this really horrible sort of infection that can result in a lot of, I think, attacking like the nervous system and other things. So it can be quite serious and turn quite seriously. So those are the more obvious infections that you can kind of see on the surface of your skin, but there are also these more hidden or systemic infections. So I've got here endocarditis, which is a heart infection, osteomyelitis, which is a bone infection, sepsis or blood infection, and septic arthritis, which is a joint infection. So what we know from case reports is that untreated skin and soft tissue infections can turn into systemic infections. And this is obviously incredibly concerning, given that we know that people who inject drugs often feel stigmatized in primary healthcare settings. And so they may ignore the problem, or even worse, they might treat it themselves. There is a little bit of evidence coming out of a qualitative study that indicates people might be engaging in some positive behaviours as well. So people who are experiencing an abscess wound might actually leave injecting alone, or at least leave that site alone for a while until it kind of calms down. But we obviously want to encourage people to just be getting treated. So moving on to injuries, again, there are two kind of behavioural causes. So the first is just having kind of a shoddy injecting technique, either being inaccurate, so missing a vein, or just being rough. The second is injecting insoluble solutions. So when you're using drugs, you have this process of sort of making this injectable drug solution. So you'll add water to your drug, and if it has cutting agents, adulterants, or particulate matter, you'll need to filter those out using either a cotton ball, wool, or a cigarette filter. So you'll put that filter into the solution, and then you'll draw from that solution. And if you don't go through that filtration process, you could be drawing up that particulate matter and injecting that, which can just kind of wreak havoc down the vein, so causing blood clots. And that kind of brings me to these harms. So the harms like including compromised venous access. So the first one, as I mentioned before, vein collapse or venous sclerosis. So it's when the vein is scarred and the blood then reroutes to a different vein, a healthier vein, and then that vein kind of just dissipates into the soft tissue. There's also chronic venous insufficiency, which is obviously a chronic condition and kind of alludes to just this, to the blood maybe not pumping through the body as efficiently as it should be. Thrombosis is a blood clot, and thrombophlebitis is sort of the reaction to the blood clot in your superficial veins. So if you have a thrombophlebitis, in your superficial veins being the ones that you can kind of see closer to the skin surface, so you might see like red track marks that are quite swollen and painful running down your veins. Deep vein thrombosis, people might have heard of it before, people can get it on planes. So it's when you have a blood clot in your deeper vein. We've got 10 sort of deep veins. A particular culprit among people who inject is the femoral vein, which is accessed commonly through the groin. And you might not necessarily see the red track marks like you would with thrombophlebitis, but you might feel this really swollen kind of running down your whole, swelling running down your whole leg. Next, we've got artery injection. So we're hoping people don't want to inject into their arteries. Best case scenario, when you're injecting a drug solution into your arteries, because your arteries send the blood out to your extremities, your veins are sending the blood into your heart and filtering the drug solution. When you're extending it out to your extremities, the drug solution is kind of creating this painful, weird sensation, like your hands, for example, or your legs. So that's sort of best case scenario, not really the desired effect that people would want. The worst case scenario is you can develop blood clots in your arteries as well, obviously. But also, if you hit an arterial wall, you could cause serious hemorrhaging. So unfortunately, that's how people know that they've hit an artery, by it resulting in hemorrhaging, and that obviously requires quite immediate treatment. Finally, I'll just comment on nerve damage. So usually in this population, we consider nerve damage as a bit of a consequence of overdose. So people passing out, compressing a nerve, and rousing hours later, and they've kind of got this long-lasting nerve pain. In this context, we're actually referring to people hitting nerve endings or bulbs with their needle. I will say that that is not very thoroughly looked at in the literature, and so maybe don't quiz me on that one later. I'll move on to what, so those are the harms. I'll move on to what we need for a safe injection. So just to put it into context, these are the basic contents of a fit pack. So we've got needles and syringes, sterile needles and syringes, and if you're injecting more voluminous liquids, you might need a barrel that just kind of holds more liquid, like if you're injecting methadone syrup, for example. We have sterile water there to create that solution that I was talking about, mixing containers, filters to filter out the particulate matter. We have acid as well. So acid is used depending on the color of the heroin and the quality of it. So if it's a darker heroin, we might be using acid to break it down and make it more soluble. But there is also a problem with having too much acid in the mixture. If you're injecting too much acid, you could be also causing harm. There's also alcohol, so as I mentioned, to kind of wipe away bacteria from the skin surface. And then there's a tourniquet, which isn't always needed by people, and usually not included in a fit pack either. So this is kind of the equipment that we need to ensure a safer injection. We know that access to this equipment is fairly good in Australia relative to other countries, but it's obviously still not 100%. And in some areas, people are still relying on chemists and pharmacies, and for the most part, people will need to pay for that equipment. And so when money is in short supply, you can imagine that some of these other pieces of equipment that sort of ensure this safe or optimal injection might fall by the wayside. So that's a bit of a background. Now you're all experts in injecting related harms and what's needed to avoid them. I'll move on to the study that we conducted using the data collected from the IDRS. So as I mentioned earlier, the evidence around injecting related harms is quite piecemeal. Previous studies have largely looked at harms separately or as this sort of vague collective. We do know that there are risk characteristics that overlap between these harms, and there's also some that differ across harms. We also know that people are presenting with multiple injecting related harms at once. But we wanted to get a better idea and a better understanding of how these harms clustered together in a community sample of people who inject, and also how, what characteristics and what behaviours are correlating with these clusterings. So we have a really unique opportunity to do that with the ELISA drug reporting system. We used last year's data from 2019, and I would just want to begin by acknowledging all the participants who are involved in the IDRS every year and give us the opportunity to answer these questions. And I'd also like to acknowledge the Drug Trends team who always do such an amazing job at managing the project. So the IDRS has been running for over 20 years. It collects data from about 1,000 people who inject drugs regularly, and they are recruited from harm reduction sites from each capital city in Australia. And I will note harm reduction sites, so these people who are sort of engaged in these services already. We ask questions regarding demographics, drug use history, drug market trends, injecting practices, overdose history, treatment engagement, mental health, and last year we asked questions related to past month experience of those harms on the slide there. So we have nerve damage, artery injection, skin and soft tissue infection, thrombosis, deep vein thrombosis, endocarditis, sepsis, septic arthritis, and osteomyelitis. Oops. So my study aimed to do three things. The first was to estimate the number and proportion of participants who reported these various injecting related injuries and diseases. It was then to determine clusters of participants based on their reporting of these harms using latent class analysis modelling. And finally, to determine which characteristics and drug use practices were associated with these clusters. And we did this using class-weighted regression analysis. So what did the sample look like? It was fairly typical of a sample of injecting drug users in Australia. So about 2/3 of the sample were men. We had 18% who were in unstable accommodation. About just over a third were engaged in opioid agonist treatment. Nearly half reported past 6 months mental health problems, including undiagnosed issues. And then 34% reported at least one injecting related injury or disease. So I've got to say that that was actually quite surprising to us. It was quite a high number of people reporting these harms. Here is the breakdown of the number of harms people reported. So we have 65% of people, or 588 participants, who didn't report any harms at all. There were 19% or 166 participants who reported just one type. We had 10% or 89 participants reporting 2 types. And then we had 6% of participants reporting 3 or more types. The most harms a participant reported was 6, which when you think about the clinical implications of these harms and the recency of these harms, it's pretty jarring to think about someone dealing with 6 of these harms at once. So this is a graph representing the proportion among the total sample reporting each harm. The gold shading is women, and we found that nearly 1 in 5 people reported nerve damage in the past month. 14% reported an artery injection, 12% reported skin and soft tissue infection, 7% reported thrombophlebitis. There were 3% who reported endocarditis and 2% or less reporting deep vein thrombosis, sepsis, septic arthritis, and osteomyelitis. So there was someone in each category basically, which was surprising to us again. And I know that these numbers seem quite small, but they were much bigger than anticipated. I can show you why in the next slide. So here we have the results from last year in yellow bar. We also have the results from the IDRS in 2007 and 2012. So those are the 2 years where we asked similar questions. I will note that skin and soft tissue infections in the previous years were separated out between cellulitis and abscess wounds. But it kind of looks like there's this mild, steady increase or roughly the same kind of reporting for each of these harms. But then you realize that in 2007 and 2012, we asked about past 12-month experience of these harms, not past month experience. And so there's an 11-month gap where, we don't know about for these particular participants. And I know that it's methodologically problematic to compare these, and I can probably hear my supervisors right now being like, but it is just to kind of give you an example of why we were so surprised at how high these numbers were. And I think the one to point out in particular is endocarditis. So I think there was over 20 participants who reported past month endocarditis, which is incredibly high. But also there is other evidence based on hospitalisation data. There was a particular study in Melbourne that looked at hospitalisation data of injecting related endocarditis, and they found that it was increasing. So hospitalizations were increasing, but not increasing among the general population of endocarditis patients. And similarly, we know that in the UK and the US, the reporting hospitalizations of skin and soft tissue infections among people who inject drugs are increasing as well. So as I mentioned before, we know that untreated skin and soft tissue infections can lead to these more serious harms. And endocarditis in particular is incredibly debilitating. It's incredibly life-threatening. It's also very costly to treat. So if we have this sort of wave of patients who are presenting with endocarditis, we really need to be concerned. So moving on to the more novel findings of the study, we ran a latent class analysis model. So we looked at, it's an analytical method that's used to cluster or group participants into classes based on their responses for certain variables. And in this case, it was injecting related injuries and diseases. We ran a 2, 3, and 4 class model, and we found that the 3 class model was the best fit. And I'm very happy to share those statistics with anyone who's interested in having a further look. But basically, we've got these 3 theoretically distinguishable groups that indicate this spectrum of severity. So we have to the left, the no IRID group. no IRID, I will call it IRID from now on, but injecting related injuries and disease is the proper full-on abbreviation. We have the moderate IRID group. So participants in this group, they were reporting 1 to 3 types of harms, and there was this increased probability of reporting an artery injection, nerve damage, and skin and soft tissue infections in particular, but also kind of modest increases in those other harms as well, compared to the no-IRID group, which are reporting nothing effectively. And then we have the high IRID group. So participants in this group were reporting at least 2 types of harms, and then there were 30% of them who were reported 4 to 6 types of harms. And you can see that thrombophlebitis was really sort of the defining harm that drove the difference between this moderate group and this high clinically complicated group. So when we wanted to look at the characteristics and behaviours that were associated with different group membership, we ran class-weighted multinomial logistical regression analysis. And this was to answer who's in these more complex clinical profile groups and how are they injecting. These were the variables that we looked at. So age and gender, housing status, duration and frequency of injecting, drugs that were regularly injected, so at least weekly in the past 6 months, injecting site on the body, injecting location, so comparing public injections to private injections, receptive needle sharing, so using equipment of someone else, reusing one's own needle, protective behaviours like using filters and swabs, being injected by somebody else, being engaged in opioid agonist treatment, and having trouble accessing sterile needles and syringes, and then finally any undiagnosed or diagnosed mental health problems in the past 6 months. So these were what we popped into the model. So when we compared the no IRID group to the moderate and high IRID group, we found these sort of characteristics. So people in this group were more likely to inject into their arm as opposed to other parts of their body. They were less likely to inject in public. They were less likely to inject daily or more frequently. They were less likely to report mental health problems. They were less likely to have trouble accessing sterile needles and syringes. And they were also less likely to reuse their own needles. And needle reuse had this sort of severity effect, which I'll touch on in a second. But I suppose none of this is necessarily surprising. This no-IRID group were kind of engaging in less serious or less harmful behaviours. When we compared the moderate group to the other two, there was only one characteristic, and that was that they were more likely to be injected by someone else. And to be honest, I'm not entirely sure what explains this relationship. The duration of injecting was the same in this group compared to the other two. So we're assuming that they have the same experience of injecting. It could point to having poorer venous access, and so just kind of needing help to find a vein, but we haven't collected that data to really know for sure. So that one's sort of still out. So when we compare the high IRID group to the moderate and no IRID group, we found that, as I said, people were much more likely to reuse needles. So I mentioned the spectrum of severity. So people who were in the moderate IRID group were much more likely to reuse their own needles than those in the no IRID group. And then people who were in the high IRID group were much more likely again to reuse their own needles than those in the moderate IRID group. So this is significant because single-use needles, they tend, after they've penetrated the skin, they'll barb and blunt the tip. And so repuncturing your skin with that needle can be quite painful and can cause vascular damage. And so that sort of ties in with this, with sort of the results of, with the overrepresentation, of thrombophlebitis in that high IRID group potentially. There were also more women in this group, so about half of the high IRID group were women compared to just a third in the no IRID group. And we do know that women are more likely to get thrombosis than men. And I only thought of this when I was writing these slides, but women are also more likely to engage in primary healthcare services. So they're more likely to kind of see their doctor, and if they do have an issue, sort of go to the hospital. So they might just be across their clinical profile more generally. They might just have spoken to their health professional about these sort of symptoms they've been experiencing. It's purely speculative, but it was just a thought that I had. So back to just quickly the variables that we didn't see a relationship with. We were quite surprised to see that age and duration of injecting had no relationship. There's a lot of evidence to suggest that the longer people are injected, the more exposed to these harms they are. Housing status didn't have a relationship. The types of drugs injected didn't have a relationship. And I'll elaborate on that in a little second. So receptive needle sharing, there was no relationship there. And I will just say that it was really low in this sample. So only 10% of participants had receptively shared needles in the previous month. But the protective factors that we thought might, influence people's participation in those groups didn't seem to either. So opioid agonist treatment using filters and using swabs didn't show a relationship with grouping. So just to expand on the implications a little bit, firstly, our results kind of indicated, at least in this sample, that it wasn't what people were injecting, but how and where. And this surprised us because, especially given the evidence around injecting tablet preparations, some great work that Shane Darke has conducted himself. So when you're injecting tablet preparations, it is quite tricky to completely filter out the cutting agents when you're diluting particularly pharmaceutical opioids, for example. So what might explain this is that regular pharmaceutical use in the sample was incredibly low. There were only 17% of participants who were regularly injecting pharmaceuticals, but also filter use was really high. So 70% of the participants reported using filters in the previous month. So that may be mediating that effect between drug type. Second, there has been this consistent need not to just to improve, coverage of sterile equipment, and not just to reduce the risk of blood-borne virus transmission, but also for these other injecting-related harms. So in this particular sample, nearly 50% of participants were reusing their own needles. And when you consider that that was sort of an indication of an increase, in that behaviour seemed to be driving participants into those higher complex clinical profile groups, I think that it's becomes very clear that we want to make sure every injection is covered. It's not just receptive sharing, but it's actually using one needle, one use, that's it. So removing unnecessary barriers to clean equipment. And you also know that people who go to needle and syringe programs, they might actually get needles, not just for themselves, but for their peers. And so I think that should really be encouraged. As well as that, we want to make sure that services distributing clean needles and syringes and other sterile equipment are widely implemented. This is a highly engaged sample of participants. Like I said, we recruited them from largely needle and syringe programs. 95% of them reported accessing needles from a needle and syringe program in the previous month. So who sort of knows what's happening in those areas where there are no services available. So next, I think it's important that we support people who are working on the front line to be able to improve their capacity to help people with their injecting technique. So implementing safe injecting facilities is a really great start because they've got the time, the capacity and the equipment to be able to kind of improve patient injecting so that it's at an optimal level. And obviously people who frontline service staff workers are incredibly busy, and there are all these competing priorities for different health risks, but they do have this unique opportunity of high exposure to the population where they could be potentially offering advice to improve injecting technique as well. Next, we really should be encouraging the implementation of screening and testing less serious harms at low threshold services. So there was a Canadian study that found that a wound clinic that was attached to a needle and syringe program was really effective in early detection and treatment of skin and soft tissue infections. I understand that funding is obviously always an issue, but when we do consider the costs of some of these more serious infections to the healthcare system, we could be saving millions in hospitalizations. And finally, obviously, I hope that these findings can result in some improved public health messaging, particularly around clotting disorders. So educating people who inject drugs, clinicians and other health service providers on the risks of reusing equipment, but also encouraging protective behaviours like rotating injecting sites, I think would be really great progress. So of course, there are some limitations to consider. Firstly, the data was self-report, meaning there's all the usual biases of recall and social desirability, but also just pertinent to this particular study, the harms weren't clinically verified. We do know that people who inject drugs are quite good at identifying skin and soft tissue infections and thrombosis, but we're not too sure about other harms. But I will say that when I interviewed participants, it seemed the more heinous the harm, the more like readily they recalled it, and they were pretty happy to share all their details with me. But I understand that survey data isn't perfect. I think that using hospitalisation data in collaboration with community survey data will give us actually a more complete picture of the true burden of these harms. Finally, it's not a totally exhaustive list. There was a couple I mentioned earlier, like wound botulism and necrotizing fasciitis and even amputation, that are obviously incredibly serious and important to investigate. But as everyone knows, I had to be selective. The IDRS isn't intended to look at my particular PhD question, so I couldn't be too greedy with question space. And just as a final comment, I will just say that this is definitely an area that warrants further research. I probably sound like a bit of a broken record, but there are very simple modifiable behaviours that prevent the development of bacterial infections and injuries. And implementing and scaling up these intervention efforts will definitely pay for itself when we consider the money that we spend on hospitalising patients with endocarditis or sepsis and other serious infections. So I want to just finish again by acknowledging the Drug Trends team and participants, and also my supervisors and collaborators on this particular projects. Definitely welcome questions, and I've got my email there in case you want to email me about anything in particular. So thank you so much for listening.
Thank you, Sam. That was just sensational. Really important work. Now we're hopefully going to be joined on the panel by Professor Michael Farrell, the director of, there he is, the director of NDARC, who's going to put his camera on, I hope, Michael. But of course, Michael, for decades beyond count, before he came to Australia, was a drug and alcohol physician in the United Kingdom. So I think it'd be interesting to get the international perspective. We've got a couple of questions up here. A question from William for you, Samantha. Is there any data around, it's quite an interesting one, any data around harms for those who reported a performance and image enhancing drugs like steroids, etc., from this particular sample, or are you aware of any other data of similar thing?
So not for this particular sample. This is most of people who are using heroin and methamphetamines. I don't think steroids is particularly prevalent in this sample or cohort. But I do remember a talk a couple of years ago at the NDAC Symposium that looked at subcutaneous injection among people who are using performance enhancing drugs. And it was a similar thing with wound botulism. So because you're injecting into subcutaneous tissue as opposed to a nerve, you're exposing yourself to those bacterial infections from those wounds. So that's sort of maybe the crossover. I don't know if Michael had any other thoughts on that. But
yeah, I agree.
Yeah, I mean, one thing I would point out, I mean, I years ago did a work on deaths related to steroids, and it's a population that's very difficult to access. The population doesn't tend to answer the sort of surveys that IDRS does, but they're an important population. We've got another question here, and I think it's from Catherine, saying, looking at the injuries and the various, she's getting the impression that the urgency of injecting might be a factor, that you did talk about when and how people are injecting. Do you get a feel whether that was a relevant factor?
Definitely. Even talking to the participants this year about their needle reuse, and it'll be just a case of, I was desperate. I just and I didn't have a needle available. And I also didn't want to go and get one. People are pretty good at accessing vending machines, for example. So there's all these things in place to sort of avoid this desperate need, and that also the closing times of those services. But yeah, it does kind of come down to just thinking that reusing their own needle is a safer option. But yeah, I think that people are aware that it's uncomfortable. They can feel the barb and they can feel the pain of puncturing their skin again. But yeah, I think unfortunately it's a case of not really caring.
Speed injecting is a much more urgent phenomenon. We see high rates of overdose.
Yeah.
Look, Michael, having listened to that presentation, and with your years in the UK, are there any patterns that you think from your clinical experience differ from the UK? One thing that did come to mind that we've spoken about is possibly Candida, because I think there's more use of lemon juice in the UK. But
I think that's in Scotland particularly. But no, look, it's an excellent presentation, and I think one of the things is that clearly we've got to be careful on how we interpret some of the stuff because of the sort of cross-sectional nature of it. But what I think comes through very strongly is what you might call injecting technique, and some people having a pretty bad injecting technique in a sense.
Mm.
And when you talk to people about it, they see people who have sort of really not particularly good injecting technique, and it can be very hard to get people to change their technique.
Mm.
You know, that's one of the challenges, despite incurring significant complications sometimes. And people work really hard to try and train people around improving injecting technique. And sometimes it's, as we say, you know, sometimes as we understand ourselves, sometimes it's hard for people to change behavior. And that's sort of, it's one of the challenges, I think, for a lot of frontline workers, if they're seeing people who are getting recurrent complications. It's very frustrating for them if they can't get them to modify, you know. And some people like that may also become important to get into more structured treatment, which ideally, you know, maintenance treatment. And some people with really bad technique, ideally, if we had on-site injecting, or also for some of them, injectable maintenance treatment might be an additional thing, even though with some of the times visiting some of the heroin clinics, there was people injecting who actually didn't have very good technique, you know. So
yeah, thank you, Michael.
There's also some great YouTube videos.
Yeah.
Sorry?
There's also some great YouTube videos on how to inject properly. And I think that might be even an avenue that's a bit more accessible to younger people, because, you know, these days everyone's got a phone. So that accessing people through those kind of technologies is also a good idea.
Yeah. I think the other point is it's important not to assume because somebody's been injecting a long time that they've got good technique. You know, there's a tendency for people to assume that everybody has good technique, but they don't.
Yeah. We've got a question for you, Sam Manor. Says, great presentation. And Anna's asking, do you think most of the respondents who had injection-related harm had received a diagnosis from a doctor? And basically, was there any data on people taking these harms to a doctor or not?
Really good question. That was one of the things that we wanted to implement this year in the survey, sort of like follow-up of these harms, because we didn't really have the capacity last year, and this year because of COVID we didn't actually again have the capacity, because I think that's a really important thing, looking at self-treatment and also diagnosis and clinical treatment. Just from talking to the participants, I got the impression that if it was something more serious, then it seemed like it was like, oh yeah, my doctor said that, oh sepsis, oh that sounded familiar. So if it was something more serious like that, it sounded like participants had actually been clinically verified. With things like artery injection or nerve damage, where unless it was a really, really kind of fatal artery injection where they hemorrhaged or something, people were sort of, I don't know, that it's hard to know whether people had gotten those things clinically verified.
Yeah.
So it was a bit of a mix depending on the harm. Yeah.
I've got a question from Gabby. Just asking you to speak to gel cap injection relating harms. I mean, this was a major problem when temazepam gel fix, but that was around 2000, and it was a big problem in the UK, Michael. That preparation's gone, but I'm not sure to what extent.
I mean, at the time, that was a huge problem with people melting the gel and actually injecting it, and then when it went into the body, it actually solidified, and we had limb amputations and all sorts of things. I don't think we're seeing any of that now, though.
Sam, they're mostly injecting powders.
Yeah, I don't think so. Like I'm asking this year about Unisum gel caps. I'm not too sure exactly how many participants have reported it. I've spoken to a couple who have, but we might be seeing similar things with Unisum gel caps.
Well, that's an important thing to keep a track of because those have real potential for serious harm. Got a question from Ermila, and I'm not sure. Needle and syringe programs in New South Wales with other states, do we have a similar state coverage to states such as, for instance, Victoria?
Michael might have a better idea than me, but I do know that talking to participants in South Australia, in New South Wales, I feel like everyone I've spoken to so far has pretty much accessed needle and syringe programs. In South Australia, I definitely remember people talking about, and ACT as well, accessing equipment from pharmacies a little bit more.
Yeah.
I'm not too sure whether that has something to do with the participant groups that we've kind of just been getting in contact with. But that was my experience. So in certain places, and I think in Tasmania, there's a lot of people who access pharmacies for equipment as well.
Yeah, and there's probably a rural-urban divide there too.
Definitely.
Rebecca McKeaton, who's known to us all, thanks, Sam. Impressive work. Wondering about the issue of higher women, which is interesting. I found it very interesting because in stuff that I've been involved in the past, it's a very consistent finding.
Yeah.
And she was wondering about reusing and wondering if women might be being injected by their partners with the same needle. Because could it be, could it be a behavioural driven by a relationship?
Yeah. So I do know that women are more likely in that particular sample, 2019 IDRS, women were more likely to report being injected by someone else. And as well as kind of the reusing needle problem, there's also just what I mentioned before, like injecting technique and just sort of being a bit rough. And if you're injecting yourself, then you might be a bit more precise and a bit more careful, but when you're injecting someone else, you might not be. So that could definitely be an issue as well. But yeah, it is a bit of a consistent finding. And I did mention that thrombosis. Oh, Michael, you disagree?
I think we've got to be careful about that. It's complicated.
Yeah. I think it's probably complicated too.
I mean, it's surprising. You would have thought women would have better injecting technique, just generally more careful. But I do think one of the things.
Clarity, Michael.
But one of the things early on, remember years ago, there was a lot of stuff on actually initiating injecting. Women were actually more likely to be initiated by a sexual partner, so that there is that type of dimension to it.
Yes.
It could be far more related to situational type stuff about the types of not being able to do things in front of children, or there could be far more actual time and setting constraints for some women. I think you'd need to do qualitative work on it at a different level to figure out some of those issues.
This is more by way of follow-up comment. I won't need. Gabby asked a question on gel caps, is saying that they are seeing this with Unisum that you mentioned, and talking in particular in relation to compartment syndrome, rhabdomyolysis.
I wonder which gel caps Gab is referring to out of interest.
Unisum gel caps.
Yeah. Can you just explain what Unisum gel caps are, Sam? Do you know which? I can't remember, to be honest. Do you know, Michael?
No.
Sorry, Gab, I'm not sure which, Gabby, we're not sure which it is, but it's clearly, it's antihistamine. Thank you.
All right. Okay.
Yeah, no, that makes sense. No, that's something, well, I think that's well worth putting on the radar. Thank you, Gabby. We've got a question. Sorry, I'm just looking through this. By Joseph, a nurse practitioner in AOD, said, Is Samantha aware of increased skills in harm minimisation and use of vein finding with ultrasound in the Richmond trial? I'm not familiar with this.
Yeah.
Michael, you're aware of this?
Yeah, I mean, there's been a lot of profiling of it, and it sounds interesting. It'll be interesting to see, though, whether it does translate into, one of the problems with it might be that the people who are more attentive are the ones who come along and do that, but the other ones, the ones who are getting more of the harms, may not be engaging as much. But it's interesting to explore, and it's been a high-profile thing of the Richmond site, and it's very interesting.
Okay, well, that's worth following up. It's interesting. Unison seems to be, there's been a number of used to potentiate the effects of heroin. Antihistamines do come up in overdose tests. It's interesting, it's surprising. Old generation antihistamines.
It used to be cyclazine was the other one that people used to mix in.
Yeah. I think I said Cara says Harm Reduction Victoria is great, safe for injecting resources for those of you out there in interest. There's a comment again from Catherine Salisbury here about it might be worth quantifying. You did allude to it, but they're talking about the health costs. They must be hospital admissions. These must actually be quite expensive. You did allude to a costing, did you not, Samantha?
Yeah, so I mean, skin and soft tissue infections are also quite costly to treat as well. And but endocarditis, I'm not sure on the exact figure, but it's multiple days in hospital.
Months in hospital.
Yeah.
Endocarditis months, okay. Oh, shit.
So there's a separate study going on, which is a linkage study to pick up all the admissions and actually look at the costings around that. And that'll be, that'll provide, there's no question, but if people go in for endocarditis, I mean, the biggest problem with endocarditis is the mortality risk and the high complication rate around it and other complications. But on top of that, people can be in hospital for 2 months with treatment for endocarditis, and if they've got complications. So no, it's a very serious problem.
Yeah, I mean, absolutely. And I think it's one that it's not recognised as much, and I think your work is drawing attention to it, Sam. An anonymous attendee's just got a question. Are there studies around those under 18 who don't have access to safe injecting spaces and their risk?
That I've seen, actually. I think that's a good point. But yeah, no, I mean, I will say as a rule, like, this particular cohort is a bit of an aging cohort, which might explain some of the effects that we're seeing. Like the increases might be due to the fact that these people who are injecting are getting a bit older. That's sort of what they put it down to in the UK when they looked at skin and soft tissue infections and the increases there.
Yeah.
So yeah, looking at under 18s, I haven't seen anything looking at under 18s who haven't been able to access safe injecting sites. I'm sorry.
Yeah, no, but it's a very good question. I'm just as follow up on endocarditis, 30% mortality, 50% valve replacement, of course. And Michael, endocarditis can affect other organs other than the heart. Canada not kidney damage from embolic phenomena, osteomyelitis, a whole lot of very odd complications. Yeah. I'll just head towards wrapping up. We've got Amy, again, I suspect known to us. Great talk, Sam. So of interest to people, please see a fact sheet on safer injecting of Unison, which gives a thing related to the North Richmond Community Health PDF. There's a link there for those on Q&A. Look, I think we can wrap up there. Look, it's an area that I have a personal interest in, so I think I've found it fascinating. But it's also an area that, as some of you have alluded to, and Michael alluded, and some of the questions have alluded to, that it's actually not only the huge impact upon people who are injecting drugs, huge impact upon the health system, and to a large extent preventable. That's not easy, but it's something we need to focus on. Look, thank you for an excellent talk, and thank you, Michael, for sharing your clinical wisdom, and thank you everyone out there and for an excellent question time and for your attention, and I wish you all an excellent afternoon and evening. Thank you.
Thank you, Shane, for your
Thanks, Michael.